Good afternoon, or I should say good evening, everyone. My name is Pat Kelly, and I'm the Associate Dean for Research and Scholarship at the College of Nursing. And I want to welcome you to our 5th Scholarship and Research Speaker Series. Tonight's topic is mental health, and I have a few housekeeping items that I want to talk about before we get started. I would greatly appreciate if everyone would mute their microphones so that way we won't have any interruptions. For the best viewing experiences, please set your Zoom to speaker view. There will be 15 minutes of question and answers after each presentation. We are awarding 1.5 CEs, and in order to receive that, you need to sign in, register yourself, and then stay for the entire activity, and then complete the post-activity evaluation no later than February 18th at 5 p.m. We would greatly appreciate the feedback on the presentation and future topics that you would like to have us present. It helps us improve our program. The attached PDF to the Zoom chat provides you with the link for the post-activity evaluation. Our goal for our learning outcomes today for our mental health presentation is that 80% of all those who participate will receive, of all those who participate, you will receive an 80% or better on the test. We want you to be able to identify 2 trauma-informed care principles and 1 intervention that will reduce stress and improve mental health. There are no conflicts of interest regarding this presentation. All disclaimers and COIs have been completed and are on file for the New Mexico Nurses Association. I would like to introduce our first speaker this evening. From the University of New Mexico College of Nursing. Our first speaker is the Interim Doctor of Nursing Practice, Program Director and Associate Professor Dr. Ellen Schimmel. Dr. Schimmel has worked primarily in behavioral health and has worked with behavioral health patients and families in a family practice and specializes in treatment of patients with PTSD and anxiety disorders. She has published and presented nationally on behavioral health, evidence-based practice therapies, nursing curriculum development, and military nursing. I will now turn over the floor to Dr. Schimmel. Welcome, Dr. Schimmel.
Thanks, everyone. I appreciate it. I'm glad to see so many people here, and I'm excited to be sharing some of my work. So I'm going to go ahead and start sharing that now. So hopefully everyone can see that okay. It's my pleasure to be here. Hopefully this is a very timely topic. I've done a lot of work with PTSD and with trauma and with stress, with patient care, and trauma-informed care is one of those models that we use a lot of times when it comes to patient care and how we relate policies to taking care of patients. And I'm hoping to have, hopefully a lot of people are familiar already with trauma-informed care, but I'm going to be expanding it more to how we can really use it to take care of our healthcare workers as well. And a lot of the stuff and a lot of the research that I've done and the scholarships that I've done has to deal with nursing, but with where we're at right now, it's very common that you see this in a number of different types of frontline workers and healthcare workers outside of nursing, but a lot of the literature that I'm going to use is from nursing, just to kind of put that out there up front. So I'm excited to be with you all. Here's my outline. I'm going to talk about stress and trauma, and then review some of the current information about potentially psychological trauma and psychological consequences of nursing and healthcare work. Identify common components of trauma-informed care, and then how to use trauma-informed care for personal and professional interventions. And that's not only going to be at the individual level, but also more of the system level and the healthcare organization level. So hopefully you'll come out of here with lots of different thoughts on things that you can even implement in your practice, in your personal practice and your professional practice, leaving this session here today. So for starters, stress, it kind of has a negative connotation a lot of times, but the pathology related to stress is really not as common as resilience. And so there is a lot of work that looks at resilience and looks at resilience as a response to stress, and that we really hope that that's something that we can teach, that's something that people learn, that's something that they can apply. So just because someone has stress doesn't necessarily mean it's a bad thing, that there's a lot of growth that comes out of stress, and that's a good thing. That if, I once heard, if it wasn't for my struggle, I wouldn't have my strength. So it is in stressful situations where we can find that resilience and find our strength. And I don't want to discount that in any way as I talk about stress and trauma in regards to really being a nurse and being a healthcare worker. But there's also a big difference between what's just arousing and what's stressful and what's traumatic. And sometimes those lines end up getting very blurred. Where do we draw the line between this is a traumatic experience versus this is a stressful experience? Even the literature's not always clear about that. It really does depend on the person. And there are a lot of predisposing factors that are going to really deal with that stress response. And that ends up aligning to a lot of the drivers that contribute to poor mental health. And those are things that we think about, genetic predisposition, things like previous life experience, and then social support. And I'm going to talk more about those things and how those things really play into both using trauma-informed care as a model and kind of as the potential solutions to some of the potentially traumatic things that can happen as healthcare workers, and again, more specifically related to nursing. But trauma comes in many shapes and sizes. A lot of times we think about things like domestic violence and abuse as traumatic events, but it can be also things like bullying and cyberbullying. It can be chronic. It can be intergenerational. A lot of what's happened in the past 2 years now with COVID-19 and social unrest has also been put into that category of trauma, and not just as a traumatic event, but really enduring traumatic events that a lot of people have been exposed to. And that, as we look at how people respond to trauma in general, to kind of keep in mind that there's a lot of different things that can kind of add to the culmination of different traumatic events that can happen. And there's a lot of consequences of trauma. There's substantial adverse outcomes following trauma in general. Traumatic experiences have been linked to health problems and mental health problems and a host of unhealthy behaviors and social consequences. So some of the negative health effects of trauma, things like using alcohol and drugs and missing work and smoking and diabetes and depression and suicide attempts and sexually transmitted infections. And so a lot of you are probably very aware of that literature. We also know, and when we think about trauma, that earlier childhood trauma and adverse childhood experiences is something that's going to influence health and well-being. One thing I really like about this CDC model for ACEs, for the adverse childhood experiences, is that we know this, what I just mentioned, disease and disability and social problems can be the result of trauma. But one thing that we don't always consider is what comes before that. Really those adverse childhood experiences, which are a lot of what we consider a lot of disparities in health, social conditions, a lot of that social context, and historical traumas that, again, have really come more to light in the last couple of years, as we've really kind of taken more of a look at how we treat people in our system, in our healthcare system. And we know adverse childhood experiences, early adversity has lasting impacts, not just mental health and physical health, but also, risky behaviors and then opportunities. So educational, occupational, and income opportunities. And those things are very closely linked to adverse childhood experiences. And I do, I would take that a step further when it comes to looking at the healthcare profession and healthcare workers, frontline workers, that there are a lot of potentially traumatic events in nursing. And a lot of literature has shown that nurses often encounter events that would be classified as traumatic, such as workplace stress, such as some of the stigma and punitive and regulatory measures that go along with seeking mental health treatment, seeking treatment for substance use disorders, like having licenses taken away, or being on lists where you're being monitored, and other things like that for seeking treatment. Also, the idea of psychological re-traumatization. So, a recent study actually found that about 40% of nurses report at least 4 ACEs, and that's in contrast to the general population that only has about 12% of the population are saying that they have at least 4 of these adverse childhood events. So a lot of nurses have more adverse childhood experiences coming into the profession. And so psychological re-traumatization is very real. And not only re-traumatization of maybe something that's happened to them in the past and traumatic events that have happened either in their history or in their childhood, but then vicarious traumatization. And the difference between those two is really that the nurse is taking on someone else's trauma, and the trauma comes from hearing someone else's story as opposed to experiencing the trauma themselves. And then, of course, there's been quite a bit in the news lately, and not just lately, but in the past couple of years, but even more so, in the last couple of months, about shortages in staff, especially nursing staff. Lots of different things out there about using travel nurses and the pay and other things like that. But also bullying and incivility. There's a lot more incidents of bullying and incivility in the nursing profession, and workplace violence. Healthcare tends to be one of the more unsafe areas to work in. And it's not just that it's unsafe. Nurses tend to have a lot more workplace violence than other healthcare professions as well. And so those do lead to potentially psychological consequences then for nurses. There's actually been 3 recent papers that came out looking at the risk, and that has been reported that nurses have higher risks than the general female population of suicide, and higher risk than physicians and the general population. So nurses have high risks of high rates of depression, of anxiety, of stress, of things like substance use disorders, post-traumatic stress disorder, burnout, imposter syndrome, and moral injury. And nurses' health, I think that, there's been literature out there for some time. This is pre-COVID, that nurses have poor lifestyle behaviors, and nurses have poor health in general than the general population, and that nurses who work night and evening shifts have increased mortality. Nurses who work shift work have more incidences of things like irregular menstrual cycles, weight gain, abdominal obesity, cardiovascular disease, diabetes, Alzheimer's disease, and dementia. And nurses have higher rates of substance use disorder problems, prescription drug misuse, and energy drink use than the general population. And, this stress on our profession can impact patients as well. And patient outcomes, nurses with worse health are 26 to 70% more likely to have medication errors. Nurse burnout has been linked to higher patient infection rates, increases in falls because of things like insufficient staffing, lower patient satisfaction, and then other patient safety considerations. As you can imagine, from resulting from the health of the nurses who are taking care of them. So kind of, getting into the trauma-informed care, and I appreciate you listening to the background, because I don't want this to be all about doom and gloom here either. I think that, I do want this to be a wake-up call too, and a lot of things that we can do for ourselves and for one another, and hopefully that's what you will also take out of this. But we know that that there is this, sometimes referred to as a stress response, but this survival response, this innate fight, flight, or freeze, that is one of these two extremes of either hyperarousal or hypoarousal, that people are either ready to attack or ready to move if they need to, or completely immobilized, that this is what stress can do this is an innate response. And but when you really consider how that looks in coping behaviors, sometimes that can look like, that fight flight can look like someone who's very disruptive, or they're argumentative, or maybe someone who is very frustrated, and they find other outlets, and they use things like substances, or they use other unhealthy outlets, to kind of cope with that stress. And that freeze can look like complete disengagement, and really keeping to oneself, or being very apathetic towards self or others, or in this case, coming from a nurse who's being stressed out, maybe apathetic towards patients too. And nurses do have higher rates of PTSD, and there is a link to PTSD symptoms and what happens with that stress response. And usually when we think of PTSD, we think of 4 symptom clusters: re-experiencing increased arousal, negative thoughts and negative cognitions about events, and really having a different filter of how you process the world. And then even up to avoidance, and not even wanting to engage in activities. And so how that can look, again, what you might see from a behavioral perspective, or what you might see either in yourself or in other people, is that re-experiencing looks like distrust and disorganization, and people feeling on edge, or maybe argumentative or hostile or angry for that increased arousal, or some of that avoidance, someone being very aloof or very quiet or passive. And then those negative alterations, they could, look depressed, withdrawn, just really, why care anymore? I'm nothing I do is going to maybe help the situation, and end in more of that depressed response and apathetic response. And so if you think about that again, how that there's, we might see that those behaviors and how people are relating to others, and we might see that as a problematic staff member. We might see that as someone who I don't like to work with even. But we also want to think about why that's important, is because, some of that being on edge and distrustful is to help people remember what that loss is worth, that was something that I lost, and try to make sense of experiences. And that's one of the things the brain does to try to be healthy, is it tries to replay things, because if you think about it over and over, a lot of times it will get better, but sometimes when there is pathology, when there's symptoms, when people aren't sleeping, when they're irritable, when all these other things are going on, it might be more that you're actually, it's kind of like your brain's replaying it to really try to make sense of it, and when it doesn't make sense. And that increased arousal can look like keeping you on guard, because your brain and your body needs to be prepared in case something happens again. And that might come off as argumentative or hostile to someone else, but this is my body's reaction to what's going on, and I have to be prepared in case something else bad happens. That quiet and aloofness can actually help, again, your body and your brain's way of responding, to help you feel safe and help remove you from a situation that could potentially cause you more harm. And that some of that depressed and withdrawn and apathetic is another way to make sense of the world. If I trust the world, then what if I let my patient down again? What if I let their family down again? What if there's something that I don't have control over again? So I'm trying to make sense of the world in any way I can, in a world where I might not have the staff and the resources that I need to adequately take care of patients. There's also links to burnout. And burnout really is the idea of this physical and emotional exhaustion caused by excessive and prolonged stress. And we do often see this in healthcare in general, but it really does impact, so even if it's not about PTSD, and again, I'm not saying all nurses have PTSD, but it can be about how engaged am I? I might see someone who's losing engagement, not being as interested, or just kind of, thinking that they really can't be as effective at their job as they have been in the past. And then self-reported burnout, and this was in the American Nurses Foundation just reported this a couple months ago. Self-reported burnout increased 350% in nurses since the summer of 2020, which I don't know that surprises anyone, but it's something that we need to be talking about. There's also links to moral injury, and this actually a lot of this research came out just recently out of the University of California at Irvine. And moral injury was first described in service members returning from the Vietnam War, really seen as this insult to morality, and not just about, maybe being this idea of burnt out, but the idea that it's not about resilience. It's about, I'm challenged because I know what the patients need and I can't give it to them because I don't have the means to give it to them. That this is out of my control. I don't have the resources to give them what I think that they need. And it really impacts a sense of trust, with the organization and sometimes with ourselves. It impacts self-respect. It's associated very directly with nurses' intention to leave either where they're working now or the profession in general. And a lot of nurses also have reported that there's a conflict, that they're really feeling conflicted, that the reasons I became a nurse are not matching up to my ability to care for people, and that I'm not a hero. A lot of nurses, again, in this most recent study by Jenkins and her team, they get very offended by the word hero because they don't feel like heroes. I'm not saving anyone. I actually don't have the resources to do the job that I used to be able to do. And I feel very disempowered by that. And yes, a lot of this has to do with COVID-19. So additionally, social isolation, social distancing can additionally decrease people's ability to emotionally self-regulate and just decrease overall health. And it can also increase sense of danger, can cause poor immune response, increased that survival response or that stress response. And if we're increasing that based on the situation that's going on, then you can imagine that that's just only compounding things. So physiological dysregulation and also increased risk for infection. And that isolation, earlier we talked about social support is one of those things that can be a protective factor. That's pretty significant when now we've taken that away, where you are isolated and you don't have the same communication that you've had in the past, and this loss of sense of control. And then, of course, a lot of concerns about nursing shortages, as I mentioned earlier. And so mental health effects of the COVID-19 pandemic, additionally, are a concern that just now, since COVID-19, some of the more very recent literature has looked at very high prevalence in nurses of anxiety and depression, even as compared to other healthcare workers since COVID-19 has started. And then the signs are really being influenced by long hours and fatigue and frustration. Things like not sleeping, feeling empty after not being able to take care of patients, after patients either die or are infected. Also, additionally, the worry about me getting infected or my family and friends being infected, or that I'm unintentionally infecting others, and then feeling detached and isolated from others. And then I had just spoken about a lot more morally injurious experiences really leading to that moral injury, that it's really kind of this perfect storm of these really high stakes situations, but also the environmental constraints that there's just been a lot more, just knowledge of since COVID-19, that we've really looked more and it's been a lot more evident that we're very short, that the resources aren't there, that these constraints are there, that decision making linked to any kind of survival or even social standing, that I'm maybe being blamed for decisions that are I feel out of my control because I don't have the resources to make the decisions I might have made at a different time. Also, nurses have said institutional betrayal and low organizational support. Those are predictors of moral distress. And then linking that also to depression, anxiety, suicidal ideation, plans to leave the profession, decreased enthusiasm about the job and about being a nurse, and then decreased connection to patients. So as I've been kind of talking about these different links and how that relates to that survival response, you can kind of imagine how, again, this is really just being compounded. And additionally, part of the concern that we have is the stigma that our culture doesn't necessarily support help-seeking behaviors. In fact, some some areas of nursing and some nursing boards and state boards of nursing actually are punitive when it comes to help seeking behaviors, such as seeking behaviors for substance use disorders and mental health. And then really that I should be able to handle this. And then the feelings of embarrassment and pride that are getting in the way. Other things that can happen is only people that have been through something like this could possibly understand this. So why would I seek help? Because no one's going to understand me. And really wanting someone to understand, and going back to that social support, that if I don't feel like even getting help is going to be a social support because they're not going to understand me, why would I seek any help? So negative thing to talk about, or feeling like they can't talk about it. And then a lot of times, again, where's the difference between that safety and the ethics? Like, I came into nursing to help people and I can't do that. And I feel like a failure because of that. And so why would I want to admit that to someone else? And really being isolating, because sometimes a lot of nurses have said that they worry about telling their stories and putting that on other people. And that why would I put that burden on someone else? I will just carry that burden alone. So how that links to trauma-informed care. So trauma-informed care is not designed to treat symptoms. It's components of a system to really reconsider and evaluate how to understand the role of trauma within, patient care, within our organization, within healthcare workers. And so really having this basic understanding that there is a lot of trauma in nursing. How do we use trauma-informed care to really influence what we can do about it? But trauma-informed care is very, very avoidant of inadvertently re-traumatizing people too, using participation, empowerment, working respectively and collaboratively to really promote healing and recovery for a system. And so SAMHSA, the Substance Abuse and Mental Health Services Administration, there's 6 pieces of the trauma-informed approach, and I'll go into a little more detail about these, but safety, trustworthiness, support, collaboration, empowerment, and then, really being very deliberate about cultural, historical, and gender issues. And I'll talk in more detail about these, but I think that when you think back to what I had said earlier about that stress response and that survival response and some of the coping behaviors that we can potentially see as a result from that system being amped up, hopefully you can start to understand where these things are going to fit in, where they really are going to be able to help kind of bring that down and help us recognize what would be helpful in this situation. And so when it comes to individual well-being, and this is just kind of more of a list to have you consider things, because I feel like we see these things all the time, and I don't, it's not, sometimes just seeing it again, like maybe it can help. But a lot of times we put this idea that, well, if you're more resilient and if we focused on the individual, which is why I'm gonna get into also what we can do at the organizational level, but thinking about how we utilize, not just from an individual, like just me, but how I look at what do I do with my peers? How do I use social support? How do I share experiences and stories with other people without feeling like I'm burdening them? What are resilience activities that I do incorporate in my life? And when do I make time for those kind of things? And then how do I seek out services if I need them and encourage other people to seek out services? If I see these things in someone else, would I feel comfortable intervening or saying, hey, can I take you to resources? Do you know what resources are available where you could take someone else? And what are you doing for self-care? Again, learning and recognizing those warning signs, sometimes letting people see you take care of yourself. I had been in the military for about 23 years before I retired and came here, but I had a couple of commanders who actually came every week or every other week for their mental health appointment, and they didn't want to talk about anything, but they wanted their soldiers to see that they were coming to mental health, and that was the only reason that they came in. And I mean, I thought it just was such an intentional way to let your people know that, hey, you know what, I struggle too, and I'm actually doing something about it, and I encourage you to. and again, understanding what resources are available. So the other thing I did was I just kind of use these 6 factors of trauma-informed care to put out some general information. And I have no problem sharing this too, because I know there's a lot on this slide, but just kind of picking out some things that, when we think about safety, what helps you and your peers, your colleagues, whether it's at home or at work, what helps you feel safe, not just psychologically and physically safe. So is our workplace standards being followed? Are workers being supported? What is trust? Moving on to trustworthiness and transparency, is there open dialogue? Do we listen to our employees? Do we listen to one another? If someone came to me as a peer and needed something, what would be my reaction to them too? And then what does peer support look like? Do we feel comfortable talking about experiences with one another? Are considerations made related to stress? Collaboration and mutuality. What about teamwork? What about appreciating people for the accomplishments that they are doing and the work that they are doing? When it comes to empowerment, voice, and choice, looking at people's strengths and really focusing on strengths, giving people opportunities to be heard, and then also raising issues. If I see things going on, do I take it home and complain about it, or do I feel comfortable and I'm talking to this about people in my organization? And then what do we do to actively move past stereotypes and biases, understanding diversity? What do our policies look like, and how do we respond to diverse needs of staff? And what does inclusivity in the workplace look like? And from an individual perspective, I just wanted to also mention, because I do think I like the ANA, the American Nurses Association Healthy Nurse, Healthy Nation campaign. I think there's a lot of resources that are out there for individuals that could be utilized and could be utilized better. It does sound like ANF has put some reports out about that these resources aren't being utilized very well, but they offer mental health screenings, evidence-based programs for anxiety and depression. They have online therapists, and they actually offer a warm line, which isn't a crisis line. It's not the suicide lifeline. It really is just to call and talk to someone about some things that had happened today, things that might be bothering you, and this is confidential. They also talk about how to start a caregiver response team to do more emotional first aid for people in your organization, celebrating victories, appreciating one another. They talk about, if nothing else, take hand washing back as a moment of self-care where you can do a mindfulness exercise or do something breathing just to kind of ground yourself in that moment, and to use hand washing as kind of a prompt, because it's something that we do so frequently, or just taking a lap around the unit, doing mindfulness activities, or things together or things individually. And then just kind of another slew of things at the bottom, but gratitude and meditation and other positive kind of, focusing on what you can control, looking at how is my eating and sleeping and exercise? Am I taking care of myself? Am I limiting drugs and alcohol? Or is that the first thing I do is go home and drink? And what are some other things that are important to me? And then from a workplace perspective, again, there's a significant relationship between workplace well-being and better health for nurses. And well-being really does relate to decreased medication errors. So things that can happen that can be more related to employee engagement and satisfaction, such as having walking clubs or exercise challenges, well-being surveys to just kind of get a sense of where your staff or where your peers and colleagues are at, community events or group classes availability, or putting together something like an employee cookbook for healthy recipes, because this really does relate to lower costs for the organization. Up to 70% of healthcare spending is caused by problems associated with unhealthy choices, and as nurses, I think we know that, but that doesn't mean we always feel like we have the availability to actually do anything about it, or the time or the energy or the resources. So what can our workplaces do to really help with some of those resources? And so I just did the same thing, going in the 6 different SAMHSA trauma-informed care concepts, really for considerations for for the workplace and for workplace wellness. So what kind of verbal de-escalation training and violence prevention training from a safety perspective? What kind of bystander training is available? Bystander training is one of the maybe more evidence-based solutions, if I could call it that, one of the more evidence-based some of the research is better about bystander training related to bullying and incivility and related to even suicide prevention, that how can we teach one another to be aware of some of the signs and symptoms in other people and then intervene. And a lot of that bystander training actually came from a lot of related to sexual assault and other things like that as well. But bystander training is something that's gotten a little more clout lately. But bullying prevention, suicide prevention, how do we find more inviting spaces? How do we model work-life balance with one another? Kind of moving on to trustworthiness and transparency. What is our leaders committed to our well-being? Do we feel like we could go to a leader with issues? And if we're a leader, are we as a leader modeling that kind of behavior? The next one, from a support, do we offer well-being check-ins, not just with one another, with our staff, with our peers? What is our employee assistance and mental health services? What does that look like? Do we give people the time and opportunity to use services if they need it? Or how do we make sure that they get those resources and get there? Do we support substance use disorder, violence, mental health conditions? Moving on to collaboration, what are some more, initiatives that I just talked to more about well-being? How do we establish a sense of community? The next one, looking at empowerment, do we consider what the strengths of our staff? Are we doing anything to screen them for burnout or moral injury or PTSD or depression or anxiety? Do we look and consider any type of traumatic any type of re-traumatization or any kind of maybe vicarious traumatization exposures? And do we take staff preferences into consideration? So when you look at workforce diversification, are there benefits? Maybe it's not just that somebody needs mental health care, maybe they need other benefits. What kind of educational and even employment opportunities are available? Are there transportation and food benefits available for people who might need that? What is our messaging about equity and social justice and cultural competency? And do we do surveys? Do we kind of get a pulse of what's going on with our staff and then do something about it? And this is, in conclusion here, really is that this is kind of just summing up some of those healthcare organization level considerations, considering doing different screenings, deploying warm handoffs where you help people make appointments, where you connect them with resources, where you invest in mental health providers and training, increasing availability, and not just that, but making it available for people in your organization to take advantage of those things. Looking at bystander training and maybe offering those kind of trainings. There's a lot, and I know nurses don't like to hear this a lot of times, but there's a lot of literature saying that 12-hour shifts are really hurting our nursing staff. So really eliminating those long shifts, because they never are 12-hour shifts. They're always going to be longer. Providing safety information, proactively providing psychological support, especially during transitions, like people leaving during any type of malpractice, during any kind of diversion investigations. Those transitions tend to be some of the most vulnerable times and the highest risk for suicide in nurses. So creating transition plans when someone is leaving or retiring or moving or wanting to leave the profession or whatever that looks like, helping them with their transition plan. Other considerations, where do people live? How do we get them connected to services? How do we give them time off to be connected to those services? And how do we offer incentives? And what does our insurance plan say about mental health? Do we offer decent mental health coverage in our own insurance plan? And so those are some other considerations I do have. I do want to thank you. I'm sure we have a lot of nurses here in the crowd, and I do thank you for being in this field. I think it's a challenging field, and I'm here to support you, and I hope that you're here to support one another, and hopefully you've learned ways to do that that you can incorporate, today. I also have my reference list here at the back, but then I just put questions here. So thank you.
Thank you so much, Dr. Schimmel. Really appreciate your expertise and sharing it all with us. My name is Marlena Bermel, and I am the Director of Alumni Relations for the College of Nursing. We're now at the Q&A part of the program. So you can write your question in the chat, or you can virtually raise your hand, and I'll alternate between calling on people and reading from the chat. And we'll try and get to as many questions as we can in the time allotted. So we already have one question, and Shaylise, am I saying your name right? I think you have a question.
Yep, that's right.
Good. Okay, great.
All right. Well, thank you so much for your presentation. It was super interesting to listen to. I had a question about, I'm sorry, my hand is still raised. What branch of the military were you in?
Oh, sure. I was active duty in the United States Army for 23 years.
In the Army? That's awesome. Were
yeah.
you in the mental health unit?
I was. So I'm a psych nurse practitioner, and I was a med surg nurse for a couple of years, and then I went into being a psych specialty nurse, and then I became a psych nurse practitioner for the last 15 years in the military. So all my deployments and everything were as a psych nurse practitioner.
Oh, really?
Mm-hmm.
You had deployments. Do you think you had a positive experience in the military? I'm thinking of.
23 years. Come on, I stayed in for that long. I didn't just stay in it because I was having fun. Yeah.
That's awesome. Thank you so much.
Yeah.
Thank you. We do have a question in the chat. My question is, are there people who are helping the leaders of the organizations deal with many of the same issues the staff are experiencing?
Well, I think that's a great question. I do believe, and I actually did in our DNP program for what's called our NEOL program, I had done a talk in the summer about, how do we support one another as leaders, but then how do we support our staff as well? Because I do think that that's part of it, right? Is what are we doing to help our leadership? And I don't know that I've seen any more offered for leadership in any better way. In fact, I kind of feel the opposite. I feel like leadership a lot of times is expected to work even harder and be there even longer hours. So I don't know that I've seen anything specific. We had actually done in the American Academy of Nursing, we had done kind of a list of different resources too, and we didn't find anything more specific for leaders in healthcare. In fact, it was really a lot more of the resources available were more for the front line.
Right. Are there other questions that you have? Again, you can raise your hand or put it in the chat. Okay, we do have another one. It is fascinating that 40% of nurses report 4 or more ACEs. Are there any qualitative studies that look at why these people have chosen nursing as a profession?
Well, I'm working on one now. If I could get through IRB. I saw Yvonne out there. No, I'm just kidding. No, I am very interested.
It will, Ellen, it will.
Thanks. I'm very interested in that myself. And actually, Dr. Schneider and I had been talking about, some of the reflective papers and some of the things that we talked to students about is, some things that they've been through. And a lot of people have, sometimes they bring up that, it's actually more traumatic events sometimes that even lead them into coming into the profession, or that I saw something so, I saw someone being taken care of horribly, so I wanted to really come into this profession to, to really improve it. And sometimes I do think that that's sometimes setting ourselves up. So, but we'll work on better research for that too. Thank you.
Awesome. Do we have other questions? Oh, I do have another one in the chat. Where can we get training so that we may be able to assist coworkers?
That's a good question. So some of the psychological first aid, emotional first aid trainings that they have, I've seen are pretty good. ANA actually was offering, and I just looked at it maybe a couple months ago. They were offering a training too, where they actually had a lot of little videos where they, like how to talk to someone if you've noticed things or their behaviors change, and just kind of went through scenarios. So I know ANA had some of that, but I usually think of more of the emotional first aid trainings that they have, and there's a lot of different organizations that have that out there. And mental health first aid. Is that what she said in there? Sorry. Yeah. Is it just called mental health first? Or I think Dr. Kelly put something out there too.
There she did, yeah. Mental health first.
Yeah, it's Association of Mental Health First Aid. It's out of Washington, D.C. They have programs. It's a week program, and you can specialize in adults, children, veterans, older adults, and it's a very intensive program. And I was certified in it. And of course, COVID hit, so a lot of the community outward where we can't do. And it's for lay persons, not healthcare providers. So it's to help everybody help each other in the community. And I found it very worthwhile program. It was not that expensive, but it was very intensive. And I was very impressed with them.
Yeah, and I was actually going to say the Center for Traumatic Stress, and it looks like Mary Pat just put in the link for psychological first aid. That's an 8-hour. It is an online, and that's free. So that's another resource too for people. It's about 8 hours. I think you can kind of probably skip little pieces here and there, but that's another one too that I know I've seen, and I've gone through myself that I thought was really good. That's a great question.
Any other questions? Right. Well, thank you, Dr. Schimmel. I really appreciate it. And thank you for all your expertise.
Thanks.
Back again, I wanted to thank Dr. Schimmel again for her very informative presentation. And now we're going to move on to our second presenter. I would like to introduce our second speaker, University of New Mexico College of Nursing Psychiatric Mental Health Nurse Practitioner, Concentration Coordinator, and Assistant Professor Jennifer Schneider. That's a mouthful. Dr. Schneider has more than 15 years of expertise and experience as a psychiatric mental health nurse practitioner, counselor, and pediatric nurse working with families and children. Her research, teaching, and clinical practice focuses on promoting access to and engagement in mental health care services for children and adults. I would now like to welcome Dr. Schneider, and we look forward to your presentation this evening. Thank you.
Thank you so much for the introduction. And thank you all for coming tonight. And it's a hard act to following Dr. Schimmel's fantastic presentation, though something I'm used to because we teach a lot of our classes together in the psychiatric nurse practitioner program here at UNM. So let me share my screen. Looks like hold on, I apologize. I think you're seeing the wrong thing. Okay. Nope. That's not great either. There we go. I say it all the time to my students. We've been doing this for ever, and yet I still feel like I'm constantly making Zoom mistakes. So today I'm going to speak about UNM campus mental health during the pandemic. And I'm really excited to talk with you about some of the initiatives that we've had on campus here at UNM during this challenging time that we've been facing for the last 2 years. My objectives for this training are to discuss for a bit a tool that we developed to screen for mental health concerns here at UNM. And to determine what supports we could provide to the community during this time, and to support the mental health needs here in this community. And then talk a little bit about where do we go from here, as fingers crossed, perhaps we're starting to move beyond, oh, I shouldn't even say it out loud, but hopefully starting to move beyond the pandemic. So first of all, I wanted to thank a few of the people who've been involved in the surveys that we've done, and the people who are spearheading a lot of the initiatives here on campus, including Stephanie McIver, who's the Director of Counseling for Student Health and Counseling, Monty Angel Richardson, who is a researcher here at UNM who has helped us with data analysis, and our own Melissa Cole, who I think is here somewhere on the call, who is the DNP, the coordinator of the DNP NEOL MSN administration and administration concentrations. I just totally messed that up. She has even more of a mouthful than I do. And then also the members of the UNM mental health crisis team. And I'll tell you a little bit more about those folks as we go. So first, I wanted to start from the 10,000-foot view as I was putting this presentation together. And I was trying to think about the impact of the COVID pandemic across our lives. And I got to thinking about, when I had trouble finding one resource that really captured all of it, was how much this pandemic really has reshaped so many aspects of our society. And I think some of it reminds me a little bit, at least for myself, of the frog in boiling water, you know, and or in water that begins to boil, that so much has changed over these past couple of years that ultimately I feel like I've gotten somewhat used to. But if you think about it, really it encompasses so much of our lives, including deaths from COVID, poor health outcomes across the board, the social isolation we've faced, the increased poverty and job loss, the economic I can't say that word, disruptions, school closures, the changing nature of work. I joke that I started at the College of Nursing in March of 2020, and that all of you, as far as I'm concerned, only exist through Zoom, because I have done this entire job from that point on over Zoom. And then the strain on our healthcare system, and Dr. Schimmel has spoken about quite a bit of that, especially from the nursing perspective tonight. And then again, a little bit from this 10,000-foot view, thinking about what is the expected response to a psychological response to disasters or traumatic events. So there's been quite a bit of research on this. And there is sort of an expected cluster of experiences that people often have. So first off, an initial distress, then a longer term increase in anxiety and depressed mood. Also quite a bit about difficulty with sleeping, which is one of those things that I feel like could be its own talking about the interaction between sleep and mental illness, and the chicken and egg of how they sleep issues impact mental illness and vice versa. And then for a small percentage of people who experience a disaster or trauma, they go on to develop a diagnosis of PTSD. So in thinking about what kinds of things we expect to happen in a disaster or trauma, and then putting those expectations on the COVID pandemic as a potentially traumatic event, as again, Dr. Schimmel's talked about, to think a little bit about what some of the literature says about what's come out so far in terms of people's reactions to COVID. So for example, 40% of adults in June of 2020 reported that they had a mental health concern or were increased substance use. So 31% of those had adults reported increased anxiety, depression, or both. And 13% reported increasing or starting abusing either alcohol or another substance. And 26% reported trauma stress symptoms, and 11% considered suicide. And how does that then compare to what was happening before the pandemic? So this is looking at what was out there in the literature in 2019, comparing to what was seen in June of 2020. So in April to June of 2019, about 10% of adults reported experiencing depression or anxiety or both. In June 2020, that number was 40.9%, meaning there was a fourfold increase in the amount of anxiety and depression that people were experiencing. And then in terms of rates of traumatic symptoms, so the lifetime prevalence, or so I should say annual rate of PTSD is thought to be about little under 4%. Per year. And what we saw during the pandemic, as you saw on the last slide, was 26% of folks, or a 6 times increase in experiencing of trauma or stressor type symptoms. And then in terms of kids and adolescents, so 20.5% of adolescents during the pandemic reported experiencing anxiety, and 25% of adolescents reported experiencing depression. And that comes out of a study looking at a meta-analysis looking at multiple studies of kids across the world during the pandemic. And one of the things that they found was that that girls more than boys reported these symptoms, and also that the symptoms got worse as the pandemic continued. And so I think pointing that out, because some of this literature is from early on in the pandemic. So we developed this screening tool fairly early in the pandemic, back in June of 2020, to try to better understand the mental health needs of the UNM community. So this was developed by members of the UNM crisis response team. And what we did was we took a combination of some established, well-validated screening measures and that looked at anxiety, stress, PTSD symptoms, problem substance use and abuse, self-rated health status, and resilience. And then we added some additional questions, demographic information. We created a cumulative COVID impact score, which I'll talk a bit about in a minute, and then a free text field for people to talk about their experiences with the pandemic at that point. So in terms of the tools that we used for the pandemic, we used a number of well-validated tools that are used in both clinical practice and in research to look at some of these different areas of symptoms. So you might be familiar with the PHQ-9 and the GAD-7. These are, PHQ-9 is a measure of symptoms of depression, and the GAD-7 is a measure of symptoms of anxiety. So these are shortened screening tool versions of the PHQ-9. So a PHQ-2 with just 2 questions, and a GAD-2. So that was incorporated into the survey, as well as the perceived stress scale. So this is another screening tool that looks for clinically significant symptoms of stress. And then we also incorporated the PC-PTSD. So the PC stands for primary care. And this is a screen for PTSD symptoms that was actually developed by the VA to look at trauma symptoms. And so with this tool, the first question is, have you experienced a traumatic event? And then asking questions, if you answer yes to that, then asking questions about what types of symptoms you might be experiencing as a result of that traumatic event. Then we also incorporated into the survey the CAGE aid, which is, again, CAGE might be familiar to you. It's named for the 4 questions that are asked about alcohol use. And the CAGE aid adds substance abuse to those questions about alcohol. And so it's alcohol and substance abuse as opposed to just alcohol use. And then we also incorporated the CD risk 2, and this was the only measure that was not in the public domain. So we were able to get permission from the authors to use it, and it was really important to me to look at the concept of resilience and how people rated their resilience, as well as what types of symptoms they were experiencing. And then we incorporated a self-rated health status question. So this is a question just asking, would you say that your own mental health in general is excellent, good, fair, or poor? And there's quite a bit of literature that about the reliability of self-rated health status when it comes to medical health. And so comparing how someone would rate their health compared to a provider who's able to either examine them or review their records, and that there's pretty good congruence between what how a person rates themselves and how a medical provider would rate their health. So this is using that question, but using it in terms of rating your own mental health. And then we also asked about whether there was a negative impact that people perceived for their own mental health due to COVID. So I mentioned before, we developed this cumulative COVID impact score. So we looked at some of the things that we saw happening in the community that during the pandemic, and we wanted to come up with as exhaustive a list as we could at the time of concerns that people were experiencing, to see what kinds of concerns people in our community were experiencing here at UNM. So obviously, I mean, to me, this score has its limitations because it really doesn't rank these different impacts as any of them as more or less severe than any of the other ones. And it doesn't really explain how significant that impact might be in someone's life. So one person obviously could have one of these that was very significant in their life, while someone else might have a number of them. And so there's no real way to equate these different impacts. But the goal here was, again, to try to be able to describe some of the impacts that people are experiencing. And, you know, one of the ones that strikes me now at this point is that we included someone I care about had contracted COVID, which I don't know about the rest of you, but after Omicron, and having contracted COVID myself, I feel like everyone I know has contracted COVID in the last few weeks. So I'm not sure this would be a measure that would hold up, but at the time, early on in the pandemic, it was still less common to have someone who had experienced COVID. So what did we do with this survey? We posted the survey online using Opinio survey software. We disseminated it August to December 2020. This survey was advertised on my UNM website and through direct email to students, faculty, staff, and alumni. We were recruiting for participants at all of the campuses, so Maine, HSC, as well as the branch campuses. And participants were provided with mental health resources, including crisis support at the end of the survey. So we made sure once you completed the survey tool that you were brought to a list of resources, including some immediate crisis intervention resources if you found the survey triggering, as well as resources that were based on all of the elements of the COVID impact score, and resources for specifically for mental health care. So I'll talk a little bit about what we found. We had 1,165 total participants in the study. The average age of participants was in their 40s, and the youngest was 18, and the oldest was in their 80s. In terms of race and ethnicity, it mirrored fairly closely New Mexico's population. There was a large percentage of white European, a large percentage of Hispanic Latino folks, and then smaller percentages of other groups, though a larger percentage of American Indian and multiracial participants. In terms of campuses, we did end up with a lot of main campus and HSC, and some people who didn't report their campus affiliation, but the largest percentage was main campus and HSC. And then in terms of the affiliation with UNM, you can see we had the largest group was actually staff. We also had a large group of students, a small group of faculty next, and then a smaller group of alumni and a very small group of retirees. In terms of what people reported for their cumulative COVID impact, they reported that the average score was a 2.6 items on the COVID impact score from the COVID impact score. And you can see the data was positively skewed, as you'd expect, with the largest numbers falling between 1 and 5 reported COVID impacts. And in terms of what was most commonly reported, the largest concern that people reported was experiencing suffering due to isolation. The next highest was gaining new responsibilities and caring for others. And then someone I care about contracted COVID, which again, I think if we did now would be a much higher number. And finally, rounding out the top 4 was I experienced financial difficulty. And then you can see from this slide all of the other COVID impacts and how they were and how they fell out, with the least common that people reported were experiencing violence or abuse during the pandemic. In terms of that question of whether the COVID-19 pandemic had negatively impacted mental health, respondents reported that, so about 80% of respondents reported that either COVID had negatively or very negatively impacted their mental health, while less than 10% of respondents reported that COVID had a positive impact or very positive on their mental health. And to highlight a few of the results seen with some of the scales that we used. So with the perceived stress scale, the mean score was an 8.2 with standard deviation of 3.7. The range for that survey is 0 to 16 points. And a score between 6 and 10, where our average fell, indicates a moderate amount of stress. With the substance abuse scale, the CAGE aid, the mean score was a 0.8 with a standard deviation of 1.0. So that has a score of 0 to 4. The cutoff usually is 2, so less than 2 is considered not clinically significant. And these questions were only asked of participants who indicated that they drank alcohol or used drugs in the previous month to taking the survey. So only 564 participants participants actually answered these questions for the CAGE aid. With the resilience scale, the mean resilience score was a 5.65, standard deviation of 1.62. So that has a range of 0 to 8. There is no cutoff or clinically significant score for resilience. However, higher scores of resilience on the scale indicate higher rates of resilience. So this score would be in the moderate to high range, that folks were overall on average rating themselves moderate to high resilience. And then in terms of the COVID impact score, it was positively correlated with reported PTSD symptoms. So about 40% correlation. So as people reported more PTSD symptoms, they reported more COVID impact, higher COVID impact score. So race and ethnicity in this survey were not significant predictors of clinically significant scores on the standardized tools. So in terms of rates of depression, anxiety, PTSD. Additionally, race and ethnicity were not predictors in this survey of the number of COVID impact items selected, so that COVID impact score. And these findings are a little bit different than what's been found in some of the national studies, where there has been quite a bit of data that that people of color have faced significantly more negative outcomes, both with illness and some of these other COVID impact scores that we were looking at for this survey. Then we used multiple regression to analyze the variance in the scores with the standardized tools. And we've found that some of the scores and some of the standardized tools accounted for some of the variability in COVID impact scores. So 16% of the variance with the PTSD tool, 14% of the variance with the perceived stress tool, 10% of the variance with the resilience tool, and then just 3% of the variance with the CAGE aid, the substance abuse tool. So now I'd like to move on to talk a little bit about what we've done with this data. One of the things that happened is that we've increased the membership and activity of the crisis mental health team. This is a UNM-wide committee that's made up of the heads of the mental health services at all of the campuses, including the branch campuses at UNM, as well as administrators across the university who are involved in supporting students and staff, and then a couple of faculty like myself. And so this committee existed prior to the pandemic, but once the pandemic hit, this committee pivoted to really focusing on the mental health needs of the campus and figuring out how to meet those needs during the pandemic. One of the things that ended up happening fairly early on in the pandemic was some expanded mental health services for the UNM branch campuses by doing things like contracting with local providers in those communities, and some agreements with Student Health and Counseling, or SHAC, which is the services here at UNM main campus, to provide some mental health services via telehealth to students at branch campuses. And then one of the things that I was somewhat involved in that I'm very proud of was the development of the mentalhealth.unm.edu website. So this is a website that lists all of the mental health organizations on the Albuquerque main campus. And with that list, it provides updated wait times for how long it is to see someone there and how to make a self-referral or get referred to those services. It also provides links to assistance to all of the areas identified in the COVID impact score statewide. So, housing support, financial support, food insecurity support across the state. And then there's also on this site a number of online workshops and drop-in groups. Initially during the pandemic, we created a bunch of drop-in groups, which didn't end up getting a whole lot of participants. And so since then, they've moved more towards workshops that are structured around different themes, but it's a way to connect virtually with other people who have similar interests to you and to find support. And then there's also tools on this website to access some self-help assistance. So there's things like a positive psychology workbook that was authored by faculty here at UNM, and an application called TAO, or Therapy Assistance Online, which has a number of different tools for self-help support. Then as we've continued on in this pandemic, one of the things that has happened is an expansion of the charge of this mental health crisis team to meet some of the other needs that were really identified during the pandemic. So for example, the crisis mental health team had a conference in January 2022 that focused on the role of police in mental health crises and strengthening the relationship between police and mental health providers to better meet patient needs. Also, in responding to an increased number of students who were reporting having suicidal thoughts, there's been additional trainings for peer support, support for faculty and staff, because it was found that a number of faculty and staff have really struggled with having to support a student who's in crisis and the trauma that they experienced from offering support to that student, and then reaching out to the students in different, and faculty and staff in different ways to offer support. For example, Suicide Awareness Week activities that happened this past fall. Oh, I apologize. Slide too far. So in the past year, one of the things we did was a mental health first aid initiative. So some of us got trained actually through the mill levy that in Rio Rancho that supports the UNM and the hospital there. Some folks from UNM main campus were also able to attend those trainings to become trainers in mental health first aid. So I know that was spoken about in the last in the last presentation that Dr. Schimmel did. This is a program that teaches participants how to recognize the signs and symptoms of a mental health crisis or challenge. We've got 2 newly trained pairs of trainers here at main campus, and we are focusing on one pair of trainers is focusing on staff, and the other pair of trainers is focusing on students. And I am one of those pairs with Dr. McIver from Student Health and Counseling, and we are focusing on students. And we actually offered the first mental health first aid training for students to our students here in the College of Nursing back in October of this year. So we had 30 participants, and it really is, it's a nice training. It's a very well thought out training that offers lay people support and how to help in either a mental health, when someone's struggling a little with mental health, all the way up to someone who's in crisis. And then we have been thinking about one of the things I wanted to make sure to point out is that I think that we've had an increased awareness about the mental health needs for everybody. I think one of the things that's come out of this pandemic is more talk about mental health, more conversation about frontline workers are experiencing, about what all of us have experienced with isolation. And so, some of the things that have come out of that. So in the College of Nursing, I have been doing a small lecture on the mental health services that are available here. Sorry, reminding me to stop. The mental health services available here in the College of Nursing, or within the UNM campus, to students who are new. So students in orientations for new programs have been receiving that information. I think that the future picture is mixed, that we have had this increased attention paid to mental health needs. There's been some increased funding towards the treatment of mental illness. I think one of the things that's happened here, both at UNM and in New Mexico as a whole, is that we have a tendency to have our resources kind of siloed, and things like there's been some work being done and more work that's continuing to be done to share those resources with one another, to make sure that we're making the best use of the available resources that are out there. But unfortunately, as we know, before the pandemic, I have a link to a study here in 2019 about the shortage of behavioral health providers here in New Mexico, and that problem is exacerbated as a result of the pandemic. And then there's also a theory that the psychological effects of the pandemic are going to actually outlast the physical effects, as they often do in disasters. So there is some literature suggesting that we are likely to even have higher rates of death due to suicide and substance abuse, all the way through to the rest of this decade as a result of this pandemic. So I think that these increased mental health needs will continue for the foreseeable future. But I want to thank you all for bearing with me tonight, and I am happy to answer any questions that you have and talk about the work to be done.
Wonderful. Thank you, Dr. Schneider. We really appreciate you sharing your study with us and all the good work you're doing. Once again, we're at the Q&A portion of our presentation. You can put your question in the chat, or you can raise your hand if you'd like. I think I already have a question in the chat. Regarding the screening tool, asking how often you've been bothered by X seems different than someone admitting he or she feels depression or empathy. One might have been depressed, but be still apathetic. He is not bothered by it. How do you differentiate being bothered by X and admitting to feeling X?
Well, so yeah, I think one of the things that tool in particular does is it's trying to get away from using terms like depression, because I think that can be a little bit of a loaded concept for people. I feel down, but I don't feel depressed. And so certainly as a psychiatric nurse practitioner, if I was seeing a patient in a clinic, I would want to explore that with them, and what that means. Depression really is a combination of a number of symptoms, including a depressed or irritable mood, or a loss of interest in things that you used to enjoy. And that's a clinical definition of depression. So sometimes I've had people who might say, well, I'm not depressed, but they really meet the criteria for depression because they've lost interest in things and they have a lot of other symptoms of depression. But what you're referring to is the PHQ-2. So that's a tool that's really, it's very much a screening tool, that if people are reporting experiencing many days in the past 2 weeks where they've been bothered by these symptoms, then the concern is that they're at risk for depression. It is not a diagnostic tool that I would, that you could say, oh, you answer these 2 questions, then you'll know for sure if you have depression. But it's really screening if you're at risk for it. That answers your question.
Yeah. We did have another question about students. Have they been included in the mental health teamwork? And can they if they want to?
Are students included in the mental health team? We haven't had students on that team, but I would be happy to take that question to that group and see if that's possible. And if you are interested, definitely please feel free to email me. And I know that there are ways that you can get involved here on campus, and that there are a lot of also student-centered activities that you could get involved in. But I think it would be great to have member representation from students on that committee as well. So yes, please do feel free to reach out.
Myself. Any other questions that we have? We do have a lot of thank yous. Just to let everybody know, we will be sharing the slides from both presentations with you probably tomorrow morning. I will email them out to you. We are recording this and it will be up on our website. Give me about a week to get it up there so you can review it or you can share it with others. Do we have any other questions? And we do have up here both Dr. Schneider's and Dr. Schimmel's email address if you think of additional questions. And we'll go ahead and put that in the chat for you as well, so you have their emails. And I just want to remind everybody that if you are looking for CEs, you do have to fill out their survey link, and I'm going to put that in the chat now as well. It must be completed by February 18th, otherwise you will not receive a certificate. And you can look to have that certificate emailed to you after the February 18th deadline, probably 2 weeks after that. Does anyone else have any questions? Okay, well, I'd like to thank everybody for attending our scholarship, research and scholarship speaker series. Our next one will be on dental health and diabetes health on April 12th. And please visit our website to get more details as that is coming in. I hope everybody has a wonderful evening. And again, look for my email tomorrow morning with the slides and resources from our presenters. Thank you again to both our presenters. We greatly appreciate your expertise.